All right. So I think we have about just under 140 people on. So I'm sure we'll have some stragglers joining a little later. So let's go ahead and get started so we can get to our presentation as quickly as possible. Welcome everyone to part two in our pharmacy access office hours on the topic of clinical pharmacy or advanced practice services in a community health center. Next slide, please. I'm not going to spend time over our mission. Webinar logistics, again, we'll have the slides available for you in Noddlepod. Again, same for recordings. And the slides, they'll all be available on the NAC 340B Archives webpage. We'll normally send you an email so you'll know that they've been published, and we'll keep you posted on that. Again, we've just chatted we just done the test for the chat, so it looks like that's working for us. All right, we're going to move on to the next slide, please. As a general reminder, office hours are supported with federal dollars, so we're prohibited from discussing anything related to advocacy in this forum. Slide. All right, so today's agenda is, as we always like to provide you with any 340B developments or updates from our 340B policy team. And then I left it on here this session as a repeat from last session. Tim and I, along with some TTA folks here at NAC, worked on a TA document entitled Pharmacy Operations Troubleshooting Guide. And the topic is on mitigating manufacturer actions impacting 340B financial savings to health centers. Just that document is in review at BIPIC. It's a publication from NAC, so that's in review from BIPIC, or the Bureau of Primary Healthcare. And once we hear back from them, their feedback, I'll be finalizing that final document, and you all should get notification of that publication link when it's available. All right, and then of course we'll have our presentation from our speakers from El Rio and Holyoke around part two of this topic, and then we'll do some Q&A. I did want to add shortly before we get to the Q&A, we've had a poll added into this presentation that we'll get to sometime in the middle of our topic presentation to gauge your appetite for an additional presentation of this part three of this topic, or if you'd like for us just to provide you with a TA document, like a technical assistance document with those additional resources. So just be on the lookout for that poll when we get to that point. All right, let's move to our next slide, please. All right, did we miss our MATS updates, Olivia? I think I had those in there.
Yep, apologies. I just have the wrong orders. Give me 1 second.
Thank you, Olivia. She's going to have Olivia switch the slides around so we can get to Matt 340B developments. All right, so I'm going to hand things over to Matt to give those 340B operational developments. Matt.
Thanks, Brandon. If we could go to the next slide, please. Okay, so I have a couple of updates for you, and I guess one request that we are asking for at NAC. The first of which I'll deal with is just dealing with kind of the collective whole of the manufacturer litigation cases. As you know, NAC and Ryan White Center and covered entities filed cases against HHS to kind of force or push along the 340B program to force HHS to finalize their ADR rule and to implement their ADR program. There were some developments that happened where, HHS released an advisory opinion, which essentially asserted that contract pharmacies are to be viewed as covered entities. Well, at the beginning of this year, as you all probably know, the manufacturers took issue with that and they sued over these issues. And so one of the developments that happened is that in May, the HRSA's Office of General Counsel sent a letter to these manufacturers and stated to them that they were to resume shipping to health centers by June 1st. They tried to do some protests or litigation moves in court to try to get around that, but none of the judges actually took them up on it. They were unsuccessful in that. And so currently where those cases sit is that these entities or these manufacturers are supposed to be shipping again to health centers. So what NAP is asking is that if you know that manufacturers have resumed shipping to your health center, please do let us know. I guess I would also say conversely, if they haven't done that, then let us know that as well. That at least just helps us to keep a pulse on where things are. The other litigation update that I wanted to bring to your attention is something that just occurred yesterday, and it's dealing with the AstraZeneca versus HHS case. It's similar to many of the other ones, but the ruling that occurred yesterday was the judge in the case denying HHS's motion to try to dismiss the matter. And really the heart of the reason why was because the judge came to the conclusion that the 340B statute is silent as to the role of contract pharmacies. And given that the judge felt that it was silent, his conclusion is that there may be more than one interpretation of the statute. Ultimately, what that means is that the judge's position is that Congress needs to make a decision as to what is a contract pharmacy's role, and is there, yes or no as to whether or not it is a covered entity. The underlying issue, though, in the case, which is whether or not HHS's advisory opinion about contract pharmacies is enforceable, that is still an issue. That was not decided yesterday. And so the case still has to do some level of moving forward to resolve that. I know that there's supposed to be a status update, I believe, either today or tomorrow. And so the policy team here at NAP will continue to stay on top of that and keep apprised of it. And certainly as more updates come, we will be sure to get those out there to the field and let you all know what's going on with these cases. Just keep in mind that, there's a lot of different cases in a lot of different districts. And so the central issue that is trying to get some form of resolution is whether or not contract pharmacies are valid as covered entities. Next slide, please. So the other development that I wanted to bring to your attention was that yesterday, HRSA announced that it was going to rescind the EpiPen and insulin final rule. So they issued a notice of proposed rulemaking. In that notice, they acknowledged that the previous rule was creating a new requirement, and that requirement was that health centers were to provide assurances that they'd established practices to provide insulin and EpiPens at or below discounted prices to patients with low incomes. And so in their notice of proposed rulemaking, they gave some level of explanation as to why they thought it would be best to rescind it. And so one of the things that they point out is that they realized that this rule was going to create a significant administrative burden because it would have required health centers to implement new protocols, new practices, new procedures. Specifically, one of the problems was that they noted that trying to meet the burden of complying with all of these new requirements would have hampered the ability of health centers to provide ongoing primary care services. And in the middle of this pandemic, which is still ongoing, they recognized that would have been, frankly, a very harmful development for health centers across the board. Specifically, another issue that they recognized is that changing the eligibility for sliding fees to 350% of the federal poverty guideline would have required the health centers to hire additional staff just to comply with those requirements. It would have required us to have essentially multiple eligibility systems and then having to build out the abilities to be able to monitor those things. So given the situation, understanding what the impact of that new proposed rule was, HRSA has decided that they would like to rescind it. And so what that means is that there's now a 30-day comment period that's open. Comments will be due by July the 16th. NAC will be providing some template comments. We are already in progress with working on that. Essentially, HHS wants to get feedback on how this rule would result in loss for health centers. And I know that when they went with the first round of things and NAC issued its comments and other health centers issued their comments, we certainly spoke up and voiced a lot of the concerns which they recognized in this notice of proposed rulemaking. So we're seeking to do that again. One of the other things I want to emphasize, though, is that even if this rule gets rescinded, there is an underlying executive order which is still a threat. And the notice of proposed rulemaking actually mentions that. So as we're working on developing this comment letter to address this rule being rescinded, we're also assessing strategies or angles to take on how to try to get that executive order taken care of. So certainly, if you have any questions, I would say reach out to the regulatory team at NAC. Our email address is regulatory-affairs@nac.org, or you can email me. My email address is mhunter@nac.org. And if you have any further questions, just say something in the chat or say something in the QA session. I'm happy to assist. Thank you.
All right. Thank you, Matt, for those updates. I'm not going to go over this again. We just mentioned I mentioned the program earlier during our overview. So we'll move on to the next slide. All right. So I'm going to quickly give things over to Alyssa with Holyoke, and we're going to get our topic started. Alyssa?
Hi, everyone. Thank you, Brandon. Okay. So it's just me joining from Holyoke today. Alexia's on vacation, and then Marissa from El Rio. All right, so as Brandon mentioned, this slide has the poll on it, but we wanted to start with a little bit of a session overview. For those of us who joined us last time, we discussed some staffing considerations as well as practice models for clinical pharmacy or advanced practice models in pharmacy. Today, we're going to talk primarily about the role of data and some clinical and advanced practice services, how the data can support that, as well as some additional service considerations. But for the third session, the poll is going to ask kind of how you want that information delivered. I'll give everybody a minute to respond.
And Alyssa, I had to take presenting privileges away from you for just a second to open this poll. So you can just let me know when you want to go to the next slide, and then I'll hand it back to you once the poll is closed. Thanks.
Olivia, can we move to the next one and still give them the opportunity to respond? Or okay.
Yep, feel free to go ahead.
Okay. So this was a repeat slide from the last deck for those of you who are just joining us this time. When I was looking at the chat briefly when everybody logged in, we definitely have people from health centers near and far. So I'm located in Massachusetts at the Holyoke Health Center. Marissa from El Rio is out in Arizona. So we represent two kind of distinct health centers, different sizes, different models, but are still running some of the same clinical services as well as some unique services. So this, again, is just a review for everybody about what are clinical or advanced practice services. They can accompany a variety of different roles. Mostly they involve direct patient care, medication management for ambulatory patients, coordination of care, triage referral, and education and self-management. Okay. These were some of the practice models that we discussed last time. So here in Holyoke, we do have outpatient pharmacy. We also have pharmacists that serve in kind of a hybrid role, bridging between outpatient and then the direct patient care services. I work mostly in direct patient care, clinical practice, and then we also have a staff member who works in academia. Marissa in El Rio also has all four of these areas covered. So we can speak to all four, but I know for someone who's trying to start these services from the ground, it can be a little bit daunting to decide where to start or what services to start with. So that's kind of where we come in to help. I'm going to give this slide over to Marissa.
Thank you, Alyssa. So very briefly, I am very appreciative of that connection because we wanted to make sure to bridge you into what we're going to talk about today. And that really is, how do you just do it? How do you get to the point where you as an organization have made the decision, this makes sense, and what next? And so the what next is really, really important because I'm sure all of us want to be on the road to success, correct? We don't want to be falling off a cliff into never, never land. And so part of that involves intentional analytics up front. And we'll also talk about analytics on the backside. But when you're planning and strategizing how best to use your pharmacy talent within your organization, I cannot emphasize the importance of preparation. So really, what is your organizational need? And how does that match up with your departmental talent? And that's what I love about working with Alyssa and Alexis from Holyoke and their incredibly effective model, is that we have come at it in two completely different ways. So unlike Holyoke, where they really built up very strong and effective clinical services from their in-house pharmacies, we really are coming from the clinic side with the advanced practice services. That was afforded to us through an opportunity through HRSA and the Office of Pharmacy Affairs to implement pharmacy practices in primary care settings, and now are carrying over those practice models into our in-house pharmacies. And so it's really, what do you have at the time you initiate and what makes sense for you? The other thing is, does direct patient care will it have the greatest impact? So do you need to see people face to face, or can you use technology to connect to individuals? So things like telehealth and or consult-based services. A lot of the new reimbursement models related to the different E&M codes these days talk about the consultation between the clinician and the provider, and really are not speaking to the interaction of the pharmacist with the patient. So just be very smart and strategic about that early setup, and also weighing supply and demand. And that's where my strongest message today will be, is don't bite off more than you can chew in the beginning. And so starting small and growing from lessons learned and developing those best practice models will get you far. So we use SMART goals as a concept commonly with patients when we're helping them to advance their self-engagement and their disease state management. But I think all of us can benefit from SMART goals, right? So being really intentional about that up front. And the next slide, we start to talk about how that alignment makes sense and the departmental alignment. So when you're looking at things, whether you're part of a formal operation or arrangement, such as an ACO as an example, or if you as an organization have just determined this is what makes sense for you, will the focus for your talent in your pharmacy department be related to closing gaps in care and helping to achieve quality metrics, especially things like decreasing the percentage of patients living with an A1C greater than 9%, or perhaps those with uncontrolled hypertension? Or are you looking more at morbidity and mortality, disease impact, truly medication-wise? So using data to say, here's our patient population that are increased risk for cardiovascular disease. Who doesn't have a statin? Who's a candidate for aspirin therapy but doesn't have that? So you could also take that kind of an approach based on what your supply is within your organization, specifically your pharmacy team. Also, the risk assessment, and this is something I know that Alyssa and I talked about via email before our presentation today, but specifically what risk in my mind, and why I included it as a bullet as part of our shared conversation today, is what are the unintended consequences of shifting your limited resources to a new service line? So let's just use an example, and I'll ask Alyssa to speak about their experience from the in-house pharmacies. But with us, if we were as a El Rio team to say, we're going to go full force, we're only going to offer Medicare annual wellness visits as an example. And we're going to do that in a tandem mode with the provider staff. Yes, there's huge benefits to that. But are we going to follow the guidelines of just checking the boxes of what CMS deems necessary for CMS? Or are we going to take more of this holistic preventive care type of concept to the next level, where we're also perhaps doing disease state management? Does it make sense to have a startup CHF clinic that's completely staffed by our APP, Advanced Practice Pharmacy staff, or does our population of 11,000 patients living with diabetes make more sense? So really just seeing when you shift that talent to these different areas, what are the gains that could be made, but also what are the possible consequences of redirecting focus that may not be what makes the most sense for your team. And then the timing and sustainability. We're in this post-COVID recovery phase. So I'm so excited that we have 173 people on the call today. That's amazing. I couldn't have asked for a better audience. But does right now make sense? Or is this where you should really be spending your time and effort on that early implementation and evaluation of services that do make sense? Alyssa, would you like to share about your experience around this before we move on?
Yeah, I would say we've had a lot of the same conversations here. I think one of the things we experience in our health center is once people get a taste of what pharmacy can do, everybody has an idea, or everybody is coming to the table with a project that a pharmacist can chime in on. So recently, one of the pediatricians brought a project to the table, and we don't usually work very closely with the pediatrics department. We're much more focused with our elderly patient population. She wanted to run some services related to pediatric asthma and hospitalizations related to asthma, and had some great ideas, but we knew that that wasn't going to be a billable service. And we had to think about, okay, like how can we implement this while not also detracting from the other services that we're offering, the COVID shots that we're giving, because our team isn't growing at this time. So it's definitely always something to consider.
One of the things that I think will help us carry into this next section about departmental alignment that both of us were able to speak to right now is also how you approach services a little differently, right? So we talked last session about honoring long-timers, people who perhaps didn't have the same educational training in the pharmacy curriculum, either chose not to or didn't have the opportunity to engage in residency training and or fellowship. They still have a really important role in this whole process of advanced practice services. But this is where you can get really creative. So as an example, I love Alyssa's point just now about the other people wanting us, right? Everybody wants us to help, and that's a great position to be in. But when you're balancing the direct services to how we also support these other projects that are really important, but we just don't have manpower to truly staff, think creatively about things like drug information services. So at El Rio, we developed, it's called Ask a Pharmacist at elrio.org. And so it's kind of our drug information hotline. It also can be used for consults. So it is not uncommon through this email system to get questions about, have you heard, or what is the primary literature that supports the use of testosterone for the treatment of migraine headache, as an example? Or my patient just moved here from Vietnam and they have all these medications. Can you please convert them to formulary equivalents? Another one, my patient has thrombocytopenia and a transient increase in liver function test. Could this possibly be drug related? So it doesn't always have to be face-to-face, although that's nice and it's great. But you can also use simple things like email to also meet the greater need of the organization, where maybe it doesn't make sense to staff an individual person or a team of pharmacists at that location, but you're honoring the request. You're just approaching it a little differently. And then that also has been incredibly useful for making that bridge, right? So again, we don't want anybody to not have a role. And can you risk non-engagement from your entire team? But maybe the question should be, how do I modify service lines to be more inclusive of the team? Next slide, please. The other thing, and I see this happen a lot, and knowing Holyoke on 2 different platforms, this experience as well as our vaccine hesitancy experience with NAC a little bit earlier this year and last year. This is something that I know we both share a lot of these same philosophies, so if people get excited, they want you to be there certain hours. But then it's a reality of people fighting for physical space. Well, we don't have any space to put you. This crunch of new workstations, making everybody feel valued. So again, that's where things where you can do things remotely or consultatively may make sense for you in the beginning. The in-person versus virtual, there's opportunities to be really effective in setting up the clinicians for having a successful encounter with their patients and having your pharmacy team use their skill and talent in their training to maximize the experience for the patient. So advanced disease state management, to deprescribe, to address polypharmacy that's going on, to make sure that care gaps are closed so that the clinician who sees them after can really focus on what the acute care issues are or things that are outside of scope for the pharmacy team members. The other thing that's been really important as well is when planning or templating, when it does make sense to have on-site advanced practice services, is to try to marry the time that you have your limited resources with that target population. And I'm going to use the example of Medicare annual wellness visits. So one of the driving services for us here is to do tandem visits for annual wellness visits. So Medicare Advantage population. And so again, when we were in that planning stage of analytics and what makes sense, we first pulled anybody who had a payer type of Medicare or Medicare Advantage and said, number one, when are they requesting appointments? And number two, when are those patients most likely to actually show or keep their appointment? And so for us, our window of opportunity is 9 a.m. until 2 p.m. Monday through Friday, and a little spattering on Saturdays. But the good news is that when we had to get down to the nitty gritty and building templates for this visit type, we really were intentional about focusing on that time period of 9 a.m. to 2 p.m. so that we were most likely to be able to meet the needs and the requests of the patients that we were hoping to engage with. So that's just one example, again, of how using that upfront planning can influence things like physical space, is it in person or is it virtual? And then also creating templates where other team members can help to schedule a patient into your service line.
Cứ đạt được lại xem không nhìn trước nhìn sau. It's hard, dude.
So we were able to discuss a little bit some of those direct patient care considerations, things that we've thought about both at El Rio and Holyoke as we're starting new services. That's kind of the checklist. Do I have the space for it? What space is required? Am I going to now, in this kind of COVID time, run the service virtually or in person? And so we've really used data at both of our health centers to answer a lot of these questions and to drive the services that we build and then to assess the productivity of those services. So I have some examples of some data dashboards that we use in Holyoke, one of which is assessing our hospital discharge follow-up encounters, the percentage of those visits that are attended by a pharmacist. The other one below is a dashboard we use actually related to some of the grant work that we do with NAC, looking at vaccination rates, specifically the Shingrix vaccine. So I would encourage you guys to develop some data dashboards or use the data services that you have to assess your need. And then once you've built these services, to also assess your productivity. So like the top one mentions, what percentage of our visits are being attended by pharmacists? And then we can take a look at the small proportion of visits that are not and assess why that is. Oftentimes it might be workflow related. They were booked into the wrong schedule, wasn't coded, so it didn't pull up when the pharmacist was doing the pre-work. It was added last minute, it wasn't communicated. And so we're able to change some protocols with the scheduling department, with the nurse teams, so that we're kind of striving for the 100% attendance rate for pharmacists in our hospital discharge visits. Also looking at quality, so gaps in care, adherence rates, that has helped us to determine where we're going to start some services, looking at quality metrics and metrics that are underperforming. That's often a way that new services are brought to our attention or kind of built. Lastly, we do look at satisfaction scores, so both our patients and our staff. So do the services that we're providing that are patient-based, like medication therapy management, do those visits fit the patient's needs? Do they feel they had enough time and that their questions were answered? But also our staff. So the hospital discharge visits, that's a big visit that we look at in terms of our staff satisfaction. when the pandemic hit, we transitioned from doing those visits in person immediately prior to the provider's visit with the patient to a day to 2 days prior to the provider's visit over the phone. And we were kind of forced to change our model because of the pandemic, but we found coincidentally that that new virtual model works a lot better. And when we sent out some satisfaction surveys to our providers, they said, you know, I like this model. I have the pharmacist notes at least 24 hours in advance of my visit, and it gives me more time to read their findings and consider their recommendations, et cetera. So I think data can be a big driver of the service that you want to implement, but then also assessing that service. Next slide, please. Marissa, I don't know if you want to talk about SMART goals.
Sure. So this was mentioned a little bit earlier, but really an example of, you know, using SMART as the guideline: specific, measurable, attainable, relevant, and time-based. Another example here that I'll use is, unlike Holyoke, we're a little bit different with our vaccine administration. And so both super effective models, great adherence rate with age-based recommendations. But in our model, as an example, because of the in-house pharmacies and because of the 2 service lines within the organization from our department, it really makes more sense for us to have the medical assistants to administer the vaccines, as an example. And so what we do here is we really want to try to maximize and have everybody working to the top of their license within scope, and then again redirect services that are more appropriate for various team members and allow them adequate time to complete those services. So here, what we might do in our model, unlike a traditional pharmacy model where the pharmacist is administering vaccines, and I know with COVID, rules have changed for interns and techs, which is great. And I hope many of those things are forever. But here the conversation may begin because our experience, and again, I don't want to only focus on COVID, but similar to what Alyssa said, lessons learned, right? There's so many things that we will take forward that we hadn't had an opportunity or that we hadn't fully explored prior to COVID. And now we have so much experience, we don't know what to do with it. But this is one where we weren't seeing people coming into the medical clinic, but we were having quite a few encounters through the pharmacy of people picking up their medications. And so we really intentionally strive to have the conversation about re-engagement, care can't wait. I mean, there's various slogans, that you can use, but the whole concept of care can't wait, and talking to our patients at the point of contact at the pharmacy window about different services, preventative care wise, that might be beneficial. And then we coordinated with our medical assistant team who has standing orders to administer those vaccines. But what that allowed us to do as a department, as a team of pharmacists, is to use our talent to then say, we had the conversation about the vaccines as an example, or the mammogram, or the standing order for other services. Those are taken care of. No labs, no A1C, uncontrolled blood pressure, pharmacist team go. And so then our clinic-based team was able to interact both, depending on the patient's preference, whether it was telehealth or in person, to help address chronic disease state management. In this example, in the context of the pandemic, and offer care that was appropriate and comfortable for the patients, so that we had hopefully less ground to make up in this recovery stage. And then the other thing I had mentioned about, and Alyssa did a great job around the accountability, is being really transparent with your dashboards. So develop those up front in the pre-planning stages, stick to them, determine who's going to run them, how often, and make sure that there's no secrets. Everybody should see what everybody's doing. There should not be any shame. There should not be any lack of transparency that exists, because it's just going to make your department stronger and your services more effective. And speaking to the overcommitting, just really look also to say, does it make sense for us to own this? Or should we be looking at community partners to provide various service lines that maybe we don't have the current staff or overhead or space to do? And how would we make that happen? Next slide, please.
All right, this slide is mine. So we wanted to take some of the lessons that we included in the other slides and kind of break it down how we applied that information to getting a service up and running here in Holyoke. So I thought asthma would be a good example, a little bit different from what I mentioned before about pediatric asthma. This service came about as a result of an organizational need. We were looking at quality metrics, our quality team was, and identified that one of the metrics we were underperforming in is patients who overfill their rescue medications, like an albuterol inhaler, and as compared to fills on their maintenance inhalers, medications they should be using every month. So in these patients, the data point will tell you that something is out of whack. Their asthma is poorly controlled, but they're not filling the maintenance medication. And thus arose this idea that pharmacy could kind of jump in and work on this metric. So we took a look at our departmental talent. What did we have and what people could we put toward this service? So we have a team already of clinical or advanced practice pharmacists. We also have several pharmacy residents that are already providing MTM or medication therapy management visits that are very comprehensive, focusing on a variety of disease states, addressing medication adherence, etc. We also have our team of outpatient pharmacists that are providing DUR, or drug utilization review, and patient counseling at prescription pickup, as this is also another source of referral to MTM. So we decided, okay, that the clinical team would run these visits to address asthma, specifically to talk to these patients and educate them about their maintenance inhalers, asthma triggers, etc. But our outpatient pharmacists could also easily identify patients that fall into this bucket when they're filling their rescue medications. And you see just lines and lines and lines of fills on that medication and no fills on the maintenance inhalers. So they're also working to provide point of care counseling at prescription pickup and also referral back to MTM if it seems that the patient needs a more extensive education session than can be offered just at the register. So we looked at direct patient care considerations like a couple slides back, things like staff time. How would we run these visits if we're relying on the same group of people and now adding an additional service line? What kind of space would we need for the visits, and also scheduling and referrals? So we decided to utilize the same group of staff, utilizing the same spaces that we've been using, although we're about to expand and get some more visit space. But since all our visits are virtual right now, the traditional visit space is not the only ones that we can use. We can use some other offices out of the patient areas that can still be used for telehealth. So we're able to do that. And then when it came to scheduling and referrals, we determined that some of the same MTM time would just be dedicated to these asthma MTMs. And we set up a new referral process so we could kind of sort them out, because we realized early on if we were using the same referral process as our regular MTMs, we would have a hard time telling who needed this targeted asthma outreach versus our other MTM patients addressing a variety of disease states. So then we looked to our analytics to kind of determine what our next steps would be. We developed data dashboards. And when our data analysts came to us with this list of patients, right, that are overutilizing their rescue inhalers, it totaled, at least about a month ago, 1,200 patients from our patient population. And so that was a little staggering, right? Because we decided we're going to run this with the same people in the same space in the same time. How are we going to make a dent on this metric when we have 1,200 patients to outreach? So we asked our data analysts to kind of layer in some other metrics or some other factors that we would consider that would make a patient a really great candidate for an MTM. So things like polypharmacy or filling 10 plus medications, patients that have an A1C greater than 9. And we layered those on top of each other. So when you get down to the bottom of our dashboard, they have asthma, this asthma diagnosis where they're filling the rescue inhaler too frequently, and they have uncontrolled diabetes. Well, there's only 16 patients that fall in both of those patient pools. And by breaking the data down a little bit more, it makes it more manageable. We can start with those 16. Maybe they're some of the most acute patients to outreach in this service, and we can go from there. So that's an example of how a new service kind of came to be in Holyoke, the considerations that we had, and how we made that manageable for our team. Next slide, please.
So I'm going to choose to speak about diabetes, and very similar to Alyssa's example with Holyoke, we had to have a similar conversation within our organization. And so at the time we implemented diabetes services and worked to develop our collaborative practice agreement that included hypertension, dyslipidemia, smoking cessation, all the other things that you would want to make sure to focus on, we did very intentionally build in medication management. So allowing the pharmacist to also use their strength and their skill set, that although the driver for the consultation may have been diabetes, that within that consultation, you may also encounter medication-related complications or other chronic disease state management issues that would require more urgent attention. And so we very clearly defined what was in scope and out of scope for prescriptive authority, and then what process would be followed within that process so that we would alert the provider, engage them early versus more of an independent practitioner type of a role. And so looking at our patient population, recognizing that there's a very large number of individuals living with diabetes within our organization, we also had to have that shared responsibility. So Relevant is a tool that we use now. I2I is something we've also used in the past. But right now, those are two really our drivers for how we use data to continue to activate our team. So first, recognize the problem, which in this case, 10,000 plus patients with a diagnosis of diabetes, of which approximately 36% have an A1C greater than 9%. And then you further drill down, very similar to Holyoke, which ones make most sense for which team member. So we can't just ignore the people who don't have an A1C greater than 9 because perhaps they're still not at goal. So they're in that in-between range of maybe 7 to 9%. But for our model, it really made sense to connect those patients to our registered dietitians and what we call health builders. So that's more of the group programming class, really focused on the education and also the engagement in a group-like setting, which lends itself well to a peer support group. And then we also had those greater than 9 that we were focusing our team effort, our advanced practice pharmacy team's effort on those with polypharmacy and or frequent hospitalizations and or the extremes, right? So your feet are in the oven or your head is in the freezer. There's not much in between. So you're 30 or you're 300, but nothing really makes sense in the middle. Those were perfect for our team. And so we very intentionally targeted those individuals. And so that's that little tiny graph on the left, how we use the data, what made sense, what was the problem, and how do we direct people. Again, very similar to Holyoke, we said, where do we have to have physical presence? So that second graph is really not to show you the detail of it, but just to recognize that we have various primary care sites within our health system model and what staff ratio made sense at each of those locations being driven by their total population, which is represented in the orange graphs of people living with diabetes. And then the red bars are those with the A1C greater than 9. And so that helped us to plan FTE presence. And then we more intentionally drill down into space, hours of the day, so on and so forth. The third graph over is speaking to productivity. And so green would be in-person visits, yellow is when telehealth entered our lives, and then the orange colored bar that's going up and down is tracking our productivity. And so we do have thresholds that we discussed very intentionally up front with the planning team, which does include finance and should include finance to help guide what makes sense as a minimum productivity. So we are not a productivity driven team. We are more aligned with a specialist or consult type of service. And so we do need a little bit more time, and because there's a lot of things that we're impacting. But on the last graph is just one example of how we measure impact. So yes, we can look at A1C reduction, but we also intentionally are capturing in this specific one that I chose to display here, knowledge. So the impact of education. So we could have very easily designed a service that was just medication titration, and there's nothing wrong with that at all. But in our case, having a formal diabetes self-management education support program that's accredited made a lot of sense because the medication titration alone wasn't working. It didn't make sense for us. So we wanted to intentionally pair that with education within the DSMES curriculum. In addition to that, we also have very intentionally measured things like when we've added this service and we've taken the time to train these advanced practice pharmacists to recognize the organizational need for closing gaps related to colon cancer screening, mammogram completion, vaccines as an example, making sure that advanced directives are completed. what has been the gain there? And so it is very clearly noted that when you activate your entire team and you remove unnecessary barriers, your patients will benefit. Next slide, please.
Okay. So that concludes the slides that we had prepared, and we have about 10 minutes or so to take questions if people want to put them in the chat.
And I believe people are able to, thank you both for this great presentation. I believe you're also able to unmute, right, Olivia? And if they're able to unmute, you can put them in the chat, or if you're comfortable unmuting, feel free to ask those questions verbally.
Hello, I believe this is William for Community Health Network down in Texas. I believe you mentioned on one of your slides in regards to having a pharmacist in a clinical practice. So I believe with the Medicare Advantage plan patients. Is there anything in the pipeline for that possibly expanding to non-private paying patient, non-private insurance patients, basically Medicaid as well?
So at El Rio, our advanced practice pharmacy services are for all patients regardless of payer. And so within that, of course, there's going to be the benefit of decreasing morbidity and mortality for those diseases that you're enabling your team to help manage, co-manage, or independently manage through collaborative practice agreements. And so overall, you know, it may be self-pay patients that you're more effectively managing because they're on more appropriate regimens. You're seeing decreased morbidity and mortality associated with their various conditions. But then also there's the reimbursement lines that do make themselves available through Medicare and Medicare Advantage. So that could include things like tandem visits for annual wellness visits, MTM, chronic care management, or CCM. Those are transitions of care encounters. Those definitely come with dollars, but the model and the concept for us, we don't limit it to a payer type. It's any patient of the health center will receive the same level of care from all team members.
That makes sense. All right, thanks a lot.
Presenters, there's a question in here from Joanna. She's other than Azara, what platforms do you use to create these dashboards and pull data?
I had mentioned that at Holyoke, we use a data service called Tableau. So the screenshots that were included on that slide are from that software. I will say, though, that I cannot make my own data dashboards in Tableau. It takes somebody who knows how to code, and we do have a data analyst team here at Holyoke. So we'll meet with them. They plug in the data that we're looking for, and then what you see is the result.
Great. And Alyssa, one targeted you. Did you say polypharmacy was 10 plus medications? It was
Yes, I
supposed
was
to be
typing to Jay. So the formal definitions will be 4 to 5 plus meds. But as I was kind of typing out at Holyoke, our patients are very medically complex. And so if we left the definition as 4 to 5 plus, almost every one of our 50 to 60 plus year old patients would qualify under that definition. So we expanded it to 10 plus to kind of hone our efforts again to try and find those patients that would benefit most from our interventions.
Thank you, Alyssa. And you all see Hannah's question in there. Is there a good resource for researching the pharmacist practice guidelines specific to your state?
So I would start with the State Board of Pharmacy, and it'll be located in your state statutes. And so depending on where you are in the United States, you may be able to engage in collaborative practice agreements, and whether or not that includes prescriptive authority, again, is very state specific. But within that, it's interesting, you can have states that say it's medication driven. So for example, you can set up an anticoagulation clinic and treat whatever possible medical condition that would result in the need for anticoagulation, versus other states may take the approach of chronic disease state management, and then you define what medications make sense for your organization. The other thing I don't want people to leave this session, whether you attended the first one today or you do the whole thing, is that start somewhere. So collaborative practice agreements are not the only way to implement advanced practice services. You can very effectively use your talent within your pharmacy department and your team to tackle non-traditional services. So an example is if it's important for you to do quality improvement projects through your pharmacy and therapeutics committee, as an example, overload that committee with data, help them to see where you can help. And I think Alyssa's example of the asthma mismatch is perfect for this, right? So you as the pharmacy team have endless amounts of data related to adherence and then claims data. So when there's mismatches for various medical conditions, make that apparent and marry that with primary literature, and then ask what will be our team's role in addressing this moving forward. So maybe it's consultative, maybe it's continuing to run dashboards that say when we engage, for example, the nurse care team, the care coordination team, or the asthma treatment program, that this is the benefit we gain by partnering and all using our talents in various ways. If you don't have a vaccine administration program, maybe that's a great place to start. So it changes the mentality of your patient population and they start to see pharmacists in a different light. And now you can start to creep into clinic-based services. Have your providers understand the power that exists in your team members and everything that your pharmacists bring to the table. And so if that starts out with maybe the pharmacist comes into the room and is there as the appointment is occurring, and then the provider is very intentionally asking the pharmacy team member to comment on what they might do, that shift in mentality for your customer, your end user, cannot be underestimated. So start somewhere. Whatever makes sense for you, but please don't leave these sessions thinking we don't have collaborative practice agreements in our state. It does or doesn't have prescriptive authority. This is just too much. Pick something and just do it.
Yeah, I agree with Marissa. We've been doing clinical services for like 10 plus years here at Holyoke, and only recently started with the collaborative drug therapy management, just because that's so complex and takes such a deep trust between the provider and the pharmacist. So we won them over with a lot of our other interventions and services, and then they wanted to do CDTM. So we started with one disease state and expanded from there.
Thank you both. Hey, Marissa or Alyssa, there is a question here from, it just says pharmacy, so I'm not sure who it is. Did you come up with any outside of the box ideas for lack of space to meet with patients other than telehealth?
I think at least in Holyoke, we're always being creative about what space that we're going to use. So if it's a designated pharmacy visit, traditionally we were running those visits out of some consultation rooms in the pharmacy, but we've expanded to using some exam rooms up on the floors. When we do CDTM, Massachusetts will say that we should be co-located with the providers when we're doing those visits. So that was the first kind of venture out of the pharmacy to use some exam rooms up with the medical providers. But we've started to do that more and more. And like Marissa mentioned, some of our visit types aren't necessarily a pharmacist visit. We're going in to do med rec and kind of work alongside the provider. So that doesn't need any additional space dedicated to us because we're kind of just jumping in tandem on the provider's visit.
Great. Just a quick little note, I see Linda put in there, checking with your state's pharmacist association just for different references. I think she was referencing Hannah's question. So just FYI, thank you, Linda, for putting that in there. All right. So just as a reminder, I don't see any additional questions. As a reminder, this session is recorded, as all our sessions are. And once the recording is published to our NAC 340B archives page, we'll make sure that link gets out to everyone who's participating in this call, so you have access to the recording and for future reference. All right. And here you see on the slide there, our health center clearinghouse. Always reference the clearinghouse if you're just looking for additional resources, so you're not reinventing the wheel. Many health centers have done some really nice promising practices. So take a look at that. You can always search using some keywords to find any projects that you're looking to do. And then lastly, on our last slide here, again, we're wrapping up year one here at NAC, and we will continue at the poll. Thank you for submitting your poll responses. We are going to do an additional third presentation based on those responses. But in addition to any comments you have in the chat, if you'd like to submit any additional questions, feel free to submit those to Tim and or I, in particular focus topic ideas. So if there's anything relevant topics that you'd like for us to highlight during our office hours, please let Tim and I know. You have our emails there. All right. And then Olivia will be sending out evaluations for this session as we all get done following this session shortly. All right. Not seeing any additional questions. We are right at time. Thanks again to the Holyoke team and the El Rio team, Marissa and Alyssa, for your wonderful presentation. And we're looking forward to seeing everyone next month for our third part of this series. All right. Thanks, everyone.